So again, welcome everyone. Thank you so much for joining us tonight for our webinar, Rethinking the Standard of Care for Cerebral Palsy. We would like to, again, just thank you all for joining. I'm going to go over a little bit of the question and answers at the end, so we will hopefully touch on all of that for you guys. My name is Jan Moskowitz. I am a licensed clinical social worker here at the Weinberg Family Cerebral Palsy Center, and I'm joined by two wonderful co-panelists. And for those of you who are new to us, I'd just like to give a little bit of an overview of who we are, so you all have an idea, and then I'll go into a little bit about your presenters tonight. For those of you who don't know, we are the Weinberg Family CP Center at Columbia University Irving Medical Center. The goal of ours is to improve the lives of people with cerebral palsy of all ages through comprehensive care, basic and clinical research, and education. Historically, as you know, doctors typically focus on pediatric medicine, and those are the ones who provide care to people with CP. But as those patients move through adolescence into adulthood, they're faced with new and emerging challenges and new health issues that require more specialized care. The CP Center serves as a medical home for these patients, and we focus on people of all ages through integrated, coordinated, and continuous care across the lifespan by physicians and staff from more than 20 different specialties. So now I'm going to introduce our panelists. First, we have Dr. Lynn Kaitis. Dr. Kaitis is an assistant professor of neurology in the divisions of movement disorders and child neurology. She obtained her medical degree from New York College of Osteopathic Medicine, followed by medical internships at the University of Cincinnati. She subsequently completed a neurology residency at New York Presbyterian Hospital, Weill Cornell Medical Center, followed by a fellowship in movement disorders at Mount Sinai Hospital. In addition to seeing adult movement disorder patients, Dr. Kaitis has a special interest in childhood movement disorders and sees pediatric patients as well. Thank you, Dr. Kaitis, for joining us.
My pleasure, thank you.
Next, we have Dr. Paolo Selber. For over 25 years, Dr. Selber has exclusively dedicated his practice to caring for patients with cerebral palsy and neuromuscular conditions. He's an internationally recognized specialist in the operative and non-operative treatment of orthopedic conditions in children and adults with cerebral palsy and other neuromuscular disorders. Dr. Selber is also the director of gait recovery for the Weinberg Family Cerebral Palsy Center and oversees a multidisciplinary team that collaborates with patients and their families to integrate gait analysis tools and technologies to best inform their lifetime care decisions. Thank you, Dr. Selber, for joining us tonight.
It's a pleasure, thank you. And thank you all for being here.
Yes, we're very excited to have this webinar. So a little bit about our program tonight. We're going to spend about 45 minutes of the program providing an overview of evidence-based treatments while also touching on some common misconceptions to better inform long-term CP care decisions regarding neurological and orthopedic treatment of CP. I want to highlight a very important part that tonight's webinar will be focused on talking more in lay terms. We're going to talk to you as parents, as people with CP, not as doctor to doctor. We want this to be a more human experience so we all kind of understand each other and get to the root of what's going on here. The goal is to break down the progression of CP to those who are the real experts, which is you all that are joining us tonight. We'll save time at the end for an interactive Q&A with the panel. And please use the Q&A function on Zoom to ask any questions during the presentation. Throughout the presentation, I'll be monitoring the Q&A, so I'll make sure to relay the questions to our panelists so they can answer any questions that you guys might have. If for some reason we run over time or your question is not addressed, please feel free to email us the question and we will email you back the answer so everything is maintaining solid communication. Our email address to email your questions is cpcenter@columbia.edu. Again, that email address to email us any questions is cpcenter@cumc.columbia.edu. Now, without any further ado, I would love to turn over the presentation to you, Dr. Selber, to talk about CP and what it actually is. The floor is yours.
Thank you, Jen. Thank you all for sharing your time with us here. We came up with this idea for the webinar because we wanted to, as Jen said, just to talk in simple terms. Not as many doctors out there do. They say words that nobody understands, and the patients sometimes leave the consulting room knowing less than what they did. So I'm gonna. This is supposed. Our plan is to make tonight the first one of a series of seminars where we're going to, in each one and every one of them, we're going to discuss a little bit of the paradigms, the world of CP as we see it. I'm going to be using very simple descriptions and very simple ways to explain what I think CP is. And that's exactly what I do when I see patients. I don't use horrible, long, complex terms. So my presentation is this one: cerebral palsy. What is it and what does it do, put simply? Okay, so let's see if I can. I have no disclosures, okay? I don't have any ulterior motives for being here to talking to you other than trying to share what I know and what I don't know about CP. There are many different definitions for CP. I like this one from the Centers for Disease Control and Prevention. They've been on fashion lately, as you all know. And they say CP is a group of disorders that affect the person's ability to move, to maintain balance, and to posture. It's a very common disability in childhood. And cerebral means brain. Palsy actually means to stop working, to pause, to, you know, if your arm can't work, it's paused. If parts of our brains are not working, the brain is a bit paused or stopped. And it tends to happen when in childhood, just before birth, during birth, and after birth. So it's important that we remember that CP is not disease, it's a syndrome. And what is a syndrome? A syndrome is what we call a combination from clinical signs and symptoms. So let me tell you what a symptom is and what clinical sign is. A symptom is when you go to the doctor and you say, I have a headache. And the doctor has to believe you because there's no way we can measure or prove or show that you have a headache. So anything that comes from the patient and the doctor cannot see, touch, feel, smell, listen to, etc., is called a symptom. A clinical sign is when the doctor can see the problem. So if you hit your arm and there is a bruise there and the skin is purple a couple of days later, you see the purple area, that's a hematoma, that's a sign, I can see it. So when you have a combination of signs and symptoms, you have a syndrome, and that's what CP is. How does it happen? And when does it happen? So it's non-progressive. It's something that happened to the brain at a certain stage, and it stopped. It was whatever happened has already finished. It stopped. It can happen before birth, whilst the baby is still in the womb. It can happen during birth, which is not very common these days with all the technologies for birth that there are around the world. But it can also happen up to the age, some people say 3.5, some people say 2.5, and some people even say up to the 5 years. And you can still call it cerebral palsy. What causes cerebral palsy? A lot of things. We can have a stroke when there's bleeding in the brain or there is not enough blood coming into the brain. We can have jaundice, which is when the liver is not working well in the baby and they are born very yellow. This is not very common anymore these days. The baby can have an infection of any sort, viral infection or bacterial, or any bug that causes a severe infection in the baby can cause cerebral palsy. And then there are the genes, and we're discovering more and more about the genetic conditions that cause the syndrome of cerebral palsy. Mom can have issues as well, and sometimes those issues can affect the child's brain. And these babies can have a trauma, you know, a car accident or a fall. And so any kind of trauma can reach the brain and cause cerebral palsy. What does cerebral palsy do? It produces movement disorders. We saw in the definition that the brain cannot control the movement very well. So we call this thing, the fact that the person with CP cannot control the movement very well, we call this a movement disorder. And there's basically 4 types these days. In the past, when I was a trainee, many years ago, we used to be taught that there are 7 types. And Dr. Kiedis will talk a bit more about that. But we have spasticity, we have dyskinesia, we have ataxia, and we have mixed. So what is spasticity, very simplistically speaking? So what happens is every time a patient with spasticity wants to relax the muscle sends a message to the spinal cord or to the brain, and the control there is not ideal. And the brain or the cord says to the muscle, I don't want you to relax. So anytime and every time the patient wants to relax the muscle, it doesn't. In fact, very often the cord, the spinal cord or the brain or together, they actually send the opposite message to the muscle. They say, no, you know what? You want to relax, but I want you to shorten. I want you to contract. So this happens because in cerebral palsy, there are certain lesions. This is where the command starts, but it needs to go all the way through this freeway before it gets into the muscle. And when this freeway is blocked, then the situation becomes limited between the muscle and the spinal cord. And the spinal cord doesn't really think. So anytime the muscle says to the spinal cord, I am relaxing, the spinal cord probably thinks that it's going to break, and the spinal cord sends a message back saying, no, I don't want you to relax. And that's in a layaway spasticity. So I know that many of you have never seen a muscle other than in the kitchen, for those of you who are not vegetarian, but you know, muscles are the stuff that moves us. You have this muscle contracting, and this one is stretching. So when this side is contracting, this side has to be relaxing, otherwise you can't do the movement. So spasticity, because it never lets the muscles relax, the muscles become stiffer and stiffer over time. And very often, not only stiff, but shortened. Their length is decreased. And as you saw in the previous slide, if it's going across a joint and it's short, then we start having what we call deformities of the bones and the body parts like hips, knees, and feet. And you can see here this person cannot stretch the knee all the way because the muscles behind her knees or his knee are too tight or too shortened or too spastic. The second type of movement disorder is dyskinesia. And this happens because this part of the brain, and this is a very cool part of the brain called basal ganglia. Basal ganglia is the person in the brain that fine tunes movement. So if we're going to shake hands, the movement comes from up above, goes through the basal ganglia, and it's the basal ganglia that controls the hand to get there where it needs to be, and so on. So in people with this dyskinesia, because the basal ganglia is not working very well, the fine tuning of the movement doesn't work very well. So anytime they want to move a part of their bodies to do something, that movement doesn't come smoothly. So ataxia is when this part of the brain, the cerebellum, is damaged for whatever reason. And this part of the brain controls a lot of things and our balance, our equilibrium. So when this part is damaged or not working well, we don't have very good balance. And, you know, the gait is unsteady. The way you're walking, we walk is unsteady. We keep the feet apart to give us more stability. We walk in a zigzag line. We are unstable. And it reminds us all of when we look at people who have had a little bit too many beers and they're going on the sidewalk and they're going from one side to the other. So ataxic, when people have alcohol in excess, they exhibit ataxic gait pattern because alcohol likes that part of the brain. So other things happen, balance impairment, and as I said, selective motor control is when you want to grab something and it doesn't work very well because we're not controlling, we're not fine-tuning the movement very well. And ultimately, there's muscle weakness, and we're going to talk a little bit about muscle weakness later. Thank you. We'll talk a bit later.
Thank you so much, Dr. Selber. Next, Dr. Katis is going to speak a little bit about what CP does to movement and some evidence-based treatments and misconceptions. Dr. Katis, the floor is yours.
Hey, thank you very much. Let me just share my screen. It says I can't share my screen.
Now you can.
Okay, there we go. Great, thank you.
I'm old, be nice to me.
That's great. Okay. Well, my name is Lynn Katis. I am a neurologist at Columbia. My subspecialty training is in movement disorders. And so through that, I've seen patients with cerebral palsy who have movement disorders. I see adults and children. And thank you for having me today. And thank you all for being here. So when I first see a patient with cerebral palsy, the first thing I want to do is make sure I have the correct diagnosis. When I see adults in particular, when they receive this diagnosis 20, 30, maybe 40 plus years ago, a lot has changed in medicine. We have more tools and we know more about the way the brain works. And so I want to make sure that we have the correct diagnosis. And so as a patient, as a caregiver, you can always talk to your doctor about how they came to that diagnosis. And I think that's important. And then another point when you may want to reevaluate the diagnosis is if your symptoms are changing. This can certainly happen with CP, like Dr. Selber so eloquently explained. In cerebral palsy, there is one injury and that's it, and it doesn't change over time. However, the brain changes over time, and the brain can adapt and manifest that injury in different ways. So it's not unusual to see changes in symptoms, but if there is a big change that's a little unusual, you do want to reevaluate, is this the correct diagnosis? Or is it another kind of movement disorder? So movement disorder is seen in patients with CP. As Dr. Selber mentioned, we have several kinds, and I'm listing them here. So spasticity, dyskinesias, which include dystonia and choreoathetosis. Choreoathetosis is just a combination of chorea and athetosis, and I'll get into the details of each of these in a bit. But dyskinesia is really an umbrella term. It sounds like a foreign language, but really all it means is dys is abnormal, kinesia is movement. So abnormal movements. And then ataxia, and then some other motor terms, which are not particular movement disorders, but other terms you may hear are paresis, which means weakness, and plesia, which means a complete loss of strength. So spasticity. So we already heard from Dr. Selber what spasticity really is. It's this increased tone. And what is tone? It is this baseline contraction in your muscle to keep postures. So when you're sitting upright, you need some contraction of your muscle to keep posture. And I actually saw someone posted a question, I think we're supposed to wait for the end, but I can try to answer it now, about why does the spinal cord think that your arm is going to break, for example, if it's moving. The spinal cord's job is to make sure you have enough tone to keep posture, but also to relax to allow movement. If that signal is not normal and it thinks that the tone should be tighter, if you try to relax, it thinks that you're stretching the muscle too much and that you're stretching it so much that it may break. And so it says, no, 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 don't break that muscle, contract more. And that creates the spasticity. So I hope I answered that question. If not, we can come back to it. And what's important about spasticity is that it increases the faster you move that body part. So when I'm checking for tone in a patient, I ask them to relax and I move the arm. If I move it slowly, I get a little bit of resistance. If I move it faster, I get even more resistance when there's a spastic limb. So this can lead to this unwanted posturing and tightening of the muscles. And this can lead to contractures, which is not an actual contraction of the muscle, but actually this shortening of the soft tissues, the tendons, the skin, and that can become tight and hold these postures. Dystonia. Dystonia is involuntary movement. So that's movement that is not in the patient's control. It's excess movement. And it can also create these unwanted posturing and twisting of the body. It can be in one small part of the body, or it can be in the whole body and everywhere in between. And it usually comes out with attempting to move. So if a patient is relaxing, you may not see the dystonia, but if they move their arm to pick up a glass or do something, they may have these extra movements. What's different about dystonia than spasticity is that dystonia will relax in sleep. And so dystonia alone doesn't lead to contractures. And then we have choreoathetosis. So these are two different, as a movement disorder specialist, we really like to fine tune exactly what we're talking about. And so chorea is derived from the Latin word meaning choreus, Latin word choreus meaning dance. So it's these dance-like, irregular, smooth movements through the body. They can be brief and random. It can actually look like the patient is restless, but they don't feel restless, which is an important distinction. And there's no clear pattern to it. Athetosis is slower, sort of writhing movements. Some people consider this on the continuum with chorea, that it's sort of a slower version of chorea, whereas other people think of it similar to dystonia, this kind of twisting and moving. Oftentimes we see these movements together and we call it choreoathetosis. Then ataxia, as Dr. Selber explained so well, is really this incoordination, and it can look like a patient who is intoxicated with alcohol. They're clumsy, they're walking unsteadily, they have some slurred speech. And the reason that someone who drinks a lot of alcohol can look like they have ataxia is because alcohol affects the cerebellum, which is the back part of the brain that controls these movements. So what are the complications of movement disorders? The main one that well, they're all important, but we look for functional ability. So are they getting in the way of regular activities that allow the patient to live independently, to walk, to feed themselves, to clean, to do other activities that they enjoy that are beyond regular daily activities? It can lead to weight loss, and this is thought to be due to high energy expenditure, a lot of movements. This combined with feeding difficulties, decreased food intake can lead to more weight loss. As we discussed, it can lead to contractures. when there's spasticity, not with dystonia, choreoathetosis, or ataxia, but with spasticity, we see contractures and pain. So do we need to treat movement disorders? Not always. If they're not bothering a patient, they're not necessarily dangerous on their own, but if they are affecting the quality of life, we do want to treat them. So how do we treat them? First and foremost is make sure you have the right movement disorder. Going back to, do we have the right diagnosis of CP? You always want to know that what you're dealing with and what you're trying to treat. Physical therapy can be very helpful for all of these conditions. And then we have oral medications and procedures, which I'll get into in a little bit more. But what I do want to mention is that it's important to be realistic about what each of these can do, what they can't do, and what are the side effects and risks of each of these. So this chart that I have here, it was published in the Lancet Neurology in 2017, which looked at the different medications that we use specifically for dystonia and chorea, but we actually use some of these for spasticity as well. And I thought it was a good review. So the first one on here is levodopa. Levodopa is always given in combination with carbidopa. The brand name of this combination is called Sinemet. The reason we give it with the carbidopa is because it blocks the side effects of levodopa. Levodopa is converted into dopamine in your brain, and dopamine helps with movement. You may have heard this medication in reference to Parkinson's disease. We use it in Parkinson's disease often, but we can also use it to treat dystonia. Oh, and I'm sorry, some of the side effects I can talk about a little bit. The main side effect is nausea. That can be easily treated with adding some extra carbidopa, taking it with food, and allowing your body to build a tolerance that usually goes away. Other things we look for are constipation and maybe some lightheadedness. The next medication on this list is trihexyphenidyl. The brand name for it is Artane. And this is something we use to treat dystonia. It's very effective in treating dystonia, and I use it often, but it does have some side effects that we want to look out for. And that can be some drowsiness, some memory difficulty. So we really want to watch. It's usually at higher doses. Blurred vision, some constipation or difficulty urinating. And all of those are really dose dependent. So the higher you go, the more likely you are to have these side effects. The next one we have is baclofen, which is commonly used to treat both dystonia and spasticity. And this works on the GABA receptors in the brain. And so it helps to relax the muscles. In a patient who does have a lot of chorea, however, we do want to watch because it can make the chorea a little bit worse. But the main side effect that I tend to see is sedation. And so, again, the higher you go in the dose, the more likely you are to have these side effects. And that's something we watch for. Okay, the next class of medications called benzodiazepines, which are used for many different disorders. They're originally used for anxiety, but we actually use them for many movement disorders, including tics and Tourette syndrome, dystonia, chorea, spasticity. So this is really a class of medications that we can use for all of them. And some common ones we use are clonazepam, also called Klonopin, diazepam, which is Valium. Next, we have tetrabenazine. And this class of medications is used to treat dystonia and choreoathetosis. It was actually originally developed for chorea, and we're starting to realize it can also help with dystonia. The main side effect with this is depression. That is the one that I worry about the most. So in a patient who has a history of depression, I would not use this because that can be a very debilitating side effect that we don't want to cause. There are newer formulations, valbenazine and deutetrabenazine, that do have less side effects. And so that can be, we're more likely to try one of those first. It can also cause some drowsiness and sleep difficulties and some Parkinsonism, which is sort of the opposite of these increased movements. It's slowed down of movements. So that's something else we watch for. And just to review, I covered the baclofen and benzodiazepines for spasticity, but what wasn't on this are second line medications are dantrolene and tizanidine. I personally don't use these much. The rehab doctors may use them more. Dantrolene, we want to watch the liver, and that's why we don't use this one as much. And we just don't have as much data on tizanidine. And baclofen and benzodiazepines tend to be effective. Ataxia, unfortunately, we don't have any approved medications for this. There are some off-label medications that I use sometimes. Amantadine is one of them that can be a little hit or miss, but it is difficult to treat, unfortunately, at this point. So now I'm going to move into some procedures that we use. And the first one that's commonly used is botulinum toxin injections. One of the brand names for this is Botox. It has many uses, as I'm sure many of you have heard of, but we use this for spasticity and for dystonia. Botulinum toxin is a neurotoxin produced by a bacterium, and it blocks the communication between the nerves and the muscles. At high doses, this can be dangerous, but we use very small doses relatively to treat spasticity and dystonia, and it is very safe in that sense. The benefit is really a result of having the correct muscle target and the correct dose. And this requires an experienced physician who can do the injection and know which muscles they're targeting. But it can take some trial and error to find out what works for you, because every patient is different and every patient will respond to different doses. The medication can take 2 to 7 days to really kick in and last on average about 12 weeks. So we give it usually at intervals of every 3 months. Some patients can go longer, and we can certainly go longer. And I did just want to mention here that my rehab colleagues will also use ethanol to treat spasticity. I personally am not trained in that, but my rehab colleagues do. And next are surgical options. And I won't get into too much detail about this as I'm not a surgeon, but I certainly have patients who have had all of these procedures. So the first thing are the baclofen pump, and that can be used primarily for spasticity, but maybe a little bit for dystonia as well. And that is when a catheter is inserted into the spine to enter the area of the spinal cord and pumps baclofen into the fluid that surrounds the brain and the spinal cord at lower doses than you would take orally, much lower doses, and that can be helpful. Deep brain stimulation is something we use for dystonia, and I have a diagram here just to demonstrate it. The neurosurgeon will drill a hole in the skull and insert a catheter into a very specific target in the brain, and it releases impulses into that part of the brain. We don't really know how it works. We don't fully understand it, but it helps regulate motor control. And it really, the target is in the basal ganglia, what Dr. Selber had mentioned. And we use this for dystonia, not just, we use it for all different kinds of dystonia, other dystonia syndromes. We also use it for Parkinson's disease. The data on cerebral palsy patients getting DBS for dystonia is variable. It's not clear cut that they all respond well, though some certainly have. And lastly, we have a selective dorsal rhizotomy, which is used for spasticity in the legs. This is permanent, and so you really want to know that this is the right next step for you. And I'm sure my surgical colleagues can talk more about this. And this is my last slide. I just wanted to mention some misconceptions that are out there, and then If there are any others, I'm happy to discuss them at the end. But one is that medications have one response in all patients. And unfortunately, that's not true. If it were true, I'd be able to predict exactly how a medication would work in every patient. But every patient is different, especially with my cerebral palsy patients, because their injuries are different. And so it does take a little bit of trial and error. We generally know how the medications work, but you know your bodies the best. And so working with your doctor and giving feedback to find the right combination is really important. More medication will equal more benefit. This is certainly not true, as some medications will cause side effects, as we discussed, but you may also hit a sweet spot with a medication, and if you go higher, you may not get more benefit. One medication at a higher dose is better than two medications together. So sometimes smaller doses of two medications can work better together than using just one medication at a higher dose. Not always true, but sometimes it is true. One pill or surgery will fix everything. And I'm sure many of you know this already, that there is no one pill or surgery that can fix everything. This is a complicated disorder, and there's a lot of different components to it that we have to use different treatments in combination. And this brings me to my next point, that one doctor can manage it all. It is a complex disorder, and we need specialists from coming at it from different angles in collaboration between them. So, for example, Dr. Selber is a wonderful orthopedist, and we share many patients together, and we work together. We use our rehab physicians and their expertise, and our social worker, like Jan Moskowitz, helps us as well, managing other psychosocial aspects of this disorder. And that's it for me. Thank you.
Thank you so much, Dr. Kadis. I know as seeing so many questions coming in, you touched on so much, which has been so helpful. We're going to get back to all those questions, but before then, I'd like to shoot it back actually over to Dr. Selber, so you could talk a little bit more about what does CP do now to muscles and bones, and some evidence-based treatments and misconceptions on that aspect. So Dr. Selber, if you want to share your screen and pick it up from there.
Thank you, Jen. Thank you so much, Lynn. It was great. I have to push everything here. And okay. Now, I'm seeing some of the questions, and some of them are, I mean, they are all terrific questions, but some of them are very difficult and hard to answer in a minute or two. Again, if you guys like this webinar, our plan is to do more of them. In each one of these webinars, we're going to discuss a bit more the stuff that we know, the stuff that we don't know, and the misconceptions. So our plan is to have another few of these. If you guys can put up with us, we would love to have you here, and we'll continue to discuss CP, cerebral palsy, in deeper detail as we go. So what I want to talk about a little bit is what CP does to the muscles and what CP does to the bones, and a little bit, just a tiny bit of a couple of treatments that perhaps may help, and some misconceptions again. So I know that many of you have never seen a muscle. Well, I hadn't seen a muscle until I became a medical student. You know, you see the beef in the kitchen, but it's a bit different. But the muscle is actually the beef that we have all over us that moves the bones. If we only had bones, our skeleton wouldn't move. So when muscles contract, when they shorten, like in the knee, these muscles, the quadriceps, they extend the knee. And the muscles in the back of your leg, they will bend the knee. So stretching the knee and bending the knee. So we always have a bunch of muscles on one side of the limb and another bunch of muscles on the other side of the limb, and they take the limb to one direction or to the opposite direction. So how does this work? Well, and again, remember that our aim here is not to discuss all these processes in details, but to give you all an idea. We don't expect, it's taken me 32 years to learn all these things. So don't feel bad if you don't learn it all in 10 minutes, because it's not the way. So we're just going to talk very briefly. I found this website, this YouTube site. I hope they're not going to be mad that I'm showing a little bit of it, but it's for a good purpose. But basically, you have the brain. The brain can think about a movement. The brain then sends messages to the nerves. The nerve gets to the spinal cord, and then there's another nerve there, and then that message gets to the muscle. And if the brain wants this muscle to contract, to shorten, then the muscle will shorten. And what happens is that as this muscle is shortening, the muscle has a few little gizmos in it, and those gizmos send messages back to the spinal cord. And the spinal cord, I use the word think, but I hope you all understand that I'm trying to put this in ways that we can understand. But what happens is that the spinal cord doesn't think anything. It has reflexes mechanisms in it. So if a message comes to the muscle, the spinal cord, saying that the muscle is stretching or contracting, the spinal cord responds with contracting the muscle if it's relaxing too much. What happens in those situations is that the brain then interferes and says, okay, the muscles is stretching because we need to do this movement. You can let the muscle stretch. This YouTube site is absolutely amazing. I wished we had YouTube in the 80s when I was in the medical school. And this is how the muscles contract. There are some proteins there, and they're aligned in a very specific way. And these proteins, they slide over this thick one here. And of course, there's one bone attached here, and there's another one attached there. And as the muscle contracts, it moves the joint, it moves the bone. So, cerebral palsy and muscles, we know, and this is a fact, and it's been published and it's been studied a lot. Cerebral palsy, unfortunately, produces or leads to muscle weakness. And of course, depending on the severity of the cerebral palsy, patients will have more or less weakness. And they also can have one bunch of muscles that are not so weak and other muscles that are more weak or weaker. I come from Australia. Sometimes we say things differently. Actually, I'm Brazilian as well. But anyway, that's another story. Why do we have weakness? Why people think that cerebral palsy patients have weakness? The first hypothesis is that because there's a damage in the brain is not able to activate, to tell the muscle, to yell at the muscle saying, I want you to contract, I want you to shorten. So because the brain doesn't send very powerful messages to the muscles don't shorten, don't contract as vigorously, as intensively. That's one possible cause. And the other cause is biology. Because the muscles are not receiving those messages from the brain as they should, the biology of the muscle starts to change. And you see, this is a cut of a muscle in a cerebral palsy patient. And this is a cut, the same cut on the typically developing patient. You can see that each one of these are cells, and there aren't much space in between these organs. In the CP patient, we start seeing more of what we call, this is the elastic substances that we have in the muscle that make it very stretchy and very elastic. And the less impulses the muscles get from the brain, the more of these changes start and occur. So the other thing is, we know that the more of this you have in your body, the stronger you are. So the thicker the muscle, the stronger you are. That's why people go to the gyms, and that's why Arnold Schwarzenegger is so strong. He's worked out very hard in his life, and he has all those big and powerful muscles. But the problem is in CP, because remember, the brain is not stimulating these muscles as much as in other people. The muscles are not so thick. The diameter is not so thick, and therefore there are people that believe that that's another cause for the weakness. And lastly, and very importantly, remember that I said that every joint has a bunch of muscles on one side and a bunch of muscles on the other side. So let's think about this. Let's believe that this is the pelvis, this is your thigh bone, this is the hip joint, this is the knee, and this is your leg bone. So you have the hamstrings, which are really, really important muscles that enable us to walk. So the hamstrings, by coming from the pelvis all the way to the leg bone, they actually pull the femur, they stretch the hip backwards. And then you have a muscle in front of your hips. We all have, I have it too, which is called the iliopsoas. And this muscle comes from the spine and from the pelvis, and it's attached on the femur from the front, and it brings the femur this way. So hamstrings extend your hips. Iliopsoas flex your hips. So stretch backward, bend forward. Now, if the brain is a bit damaged, what can happen is that impulses, messages come to both of these muscles at the same time. So the brain and the spinal cord is telling this muscle, stretch the hip backwards, and the same bunch, the brain and the spinal cord, is telling this muscle, bend this hip forward. It's almost like having two people, one on each side, pushing this thing to this side or to this side. Well, if they're both similarly strong, then you have to assume that this bone is not going to go anywhere because the forces are going to both directions. And this is what we call co-activation or co-contraction, meaning muscles on both sides of the joint are being told contract at the same time. And that's another cause for apparent weakness. And that's important because it doesn't mean that this muscle is short, or sorry, this muscle is weak or this muscle is weak. But if they're working at the same time, it looks like you can't move the leg or the arm or a hand or a finger, but not because there's weakness, but because both sides of the joint are working at the same time. What does CP do to the bones? Well, in very, very simple terms, because we have all those problems with controlling movements, many people with CP don't move as well, they don't walk as well, and many of them don't walk. They are wheelchair users. And we know that if a bone suffers compression forces, the bone gets stronger. But if there's not a lot of forces going through or effort going through the bones become more fragile. Can you see the difference here? You don't see a lot in there. And this is the shoulder of a CP patient that I treat. And this is the hip of another CP patient that I treat. This person is a wheelchair user, and this person is a walker. And therefore, there's more forces going through this bone than this bone. So if there's not enough forces, the bones tend to become more fragile. Therefore, we need to treat that. Normally, the experts in this area are the endocrinologists, because they understand bone metabolism very well, and primarily the ones that have interest, because you can be an endocrinologist and have zillions of other interests because the body is so complex. But there are people out there that will understand a lot of this fragility. And there are medications, some medications that can be used. And of course, if you can do a little bit of exercises, exercises are exceptionally important. Now, it's important that we all know this thing, the gross motor function classification system. The GMFCS has been around for approximately 20 years. It's probably, without a doubt, one of the best things that came to the world of CP. Before the gross motor function classification system, if you talk to doctors from different parts of the world, they would tell a patient is very good, or a patient is very weak, or a patient is very spastic, or this patient is not so spastic, and this is a good walker, that's not a good walker, and so on. Since the GMFCS, we started talking, we all talk in the same language. You know, the GMFCS1 patients are those patients where you can barely notice that there's a problem with muscle control. The GMFCS2 are those patients that need a little bit of support when they're going through an uneven terrain, like a stairs, or going downhill or uphill, or rocky terrain when they're doing trekking and all sorts of things. The GMFCS3 patients, they always need some sort of help. We call these things assistive devices. And they tend, when they're older, they tend to use a wheelchair for long distances. The GMFCS4s, they have very, very stubborn legs, as I say, as I like to call them, primarily to the kids, because they love the term stubborn. And because the legs are so stubborn, they don't have coordination, there's a lot of spasticity or dystonia, and there's a lot of co-contraction, there's a lot of weakness. Unfortunately, they can't stand, but they are wheelchair users. And up to a certain age, if you give them a lot of support, they're able to take a few steps and walk short distances. And this is terrific, and that's very good, because standing always puts more effort into your bones. Therefore, it makes your bones theoretically stronger. And the GMFCS5s are those patients that have a hard time controlling even their head and neck, and they need more significant help to keep to stay in a good posture, and they are solely wheelchair users. So this GMFCS classification has been tested and retested, and it's extremely helpful, because if someone wants my help from Europe, or I want somebody's help from Europe with a patient that I don't know what to do, we start discussing the case, and the first thing that people ask, if they're really into the world of CP, is, okay, what is the GMFCS of this patient? Because that gives us a good insight of how things are working, and how stubborn the legs are, and so on. So when the muscles are being so stubborn throughout life, what happens is that they keep pulling the bones in different directions, in the not normal directions. And eventually we have what we call deformities. So if the legs are deformed and the feet are not normal, and normal as in they are a bit twisted and they're a bit deformed, a bit not in the normal shape, and you already have a weak muscle. So remember, the muscles are attached to the bones, and it's the muscle that moves us. If the muscle is trying to move a bone or a joint or a foot that's not well aligned, and it's on top of everything weak, then it's hard to make these bones move, and it's hard to walk, for instance. So this is what we call levers. You know, you have the muscle is attached to the back of your foot. When the muscle contracts, it pushes your foot down, and that in return raises you up. But can you imagine this poor muscle trying to work on these feet? You know, they're very floppy, they're not in line, they're not stiff. And so the muscle tries to pull, but nothing happens because the bones are not in alignment. So it must feel like this, you know, a weak muscle trying to lift this object using this teeter-totter, which is made out of rubber. So, you know, it's hard to lift the rock because this is bending and this person is weak. So let's talk a little bit and quickly about some evidence and some misconceptions. Of course, my list of things is starting the other way around, and I am sorry for that, but this is technology. So the first thing that we need to know is that children, their body grows faster and bigger than muscle strength. And that happens to all of us. And that's why children are so active. The minute they wake up, the typically developing kids, they do stuff and they don't stop. And the GMFS1s as well, and the GMFS2s. But as children grow, their weight and their body size grows faster than the muscles. So as adults, we are all weaker than our respective size and age as a child. So we also know for sure, and there's evidence, so there is evidence for this, and there's a lot of evidence that says that every time we lengthen muscles surgically, depending on the techniques that we use, we lead to even further weakness. So if I'm telling you that it's the muscles that move the body, that move the bones, if I'm telling you that, muscles in CP are in general weak, I need to be very careful. And I'm a surgeon, I'm an orthopedic surgeon. That's what I've done for the last 25 years, is to treat these children, walkers and non-walkers. So we need to be very careful when we're lengthening muscles. And I call it dose. You know, we need to give everybody a different dose of muscle lengthening, because if we do too much, we produce more weakness. And the problem is that when a muscle has been over lengthened, the final results of that surgery don't happen immediately. Because if those surgeries took place as in the child, and because I told you that they have a lot of muscle to spare in a small body, even if you've had over lengthened muscles, it doesn't show much, because as a child, the patient has a lot to spare, but then they grow. So weakened muscles become more apparent as the child grows. It doesn't happen overnight. That's why very often, many surgeries, many techniques where they lengthen everything, the child looks very good immediately and everybody's happy, but then the long-term results, nobody shows, and and the parents are not able to correlate the long-term results with that surgery that was so beautiful a few years ago. And we do know, and there is evidence for that as well, that the younger the patients are when surgeries are done, orthopedic surgeons like the ones I do, the more unpredictable the results are, the long-term results are. Primarily but in all GMFCSs, but if we're doing surgeries for gait to make someone walk better, there is a strong belief amongst the people who study this thing hard and think about this thing every day as I do. We know that the younger the surgeries, the worse or the more unpredictable the long-term results. And I see adults as well as children, and I've always done that. So I've had the privilege over the years to see a lot of patients in adulthood with the long-term results of those surgeries that were done in children, which taught me a lot, to say the least. So I'll show you an example. This next child, this child was actually operated in another country, and we have permission to use her. Unfortunately, we don't have the video from her walking before her surgery. But according to the family's description of how she walked like this. And this is what we call a jump knee. And that's another story. We'll discuss this on another occasion. But this child used to walk with the knees a bit bent. And sometimes the parents said sometimes they were toe walking as well. So it was something in between these two types. And this is her 2 years. Now she's in the gait lab. The gait lab is where we analyze very precisely the way people walk and move, and it gives us insight of what to do. So this was 2 years after this stuff, which is very in fashion these days everywhere in the world. And let me tell you that this thing was used in the 60s and 70s, and then it was abandoned because our predecessors and our mentors thought that it wasn't very worthwhile doing. But now it's in fashion again because the wheel gets reinvented. And the parents were thrilled because they said she was walking on her toes. At times the knees were bent, and look at her now. The knees are extended, the feet are on the ground. What they're not seeing is, see those two little balls? Those two little balls are telling us where her pelvis is. And her pelvis is tilted very, very, very much forward. And you can see how she has a curvature there because her trunk is tilted forward. And one may say, well, but she's doing that because she's using the quad paws or the canes. Well, in part is that, but I can tell you that what's happened here is that those mini incisions cut a lot of the hamstrings too much. So this is 2 years post-op, and now this is 5 years post-op. And now she's showing the real results of those surgeries. And because she had very over-lengthened calf muscles, you can see how the tibias moved forward, and she can't stretch the tibias back anymore. It's the calf muscle that does that keeps this leg upright. And you may ask me, why didn't this happen 2 years post-op? Well, because she was still relatively small. She was 2 years younger. And now you can see that she's taller and she's a bit heavier. And now those muscles that are no longer there, she's missing them, and she's walking in crouch. And unfortunately, we see this over and over again, even though we've known about this stuff, not only me, but a lot of people around the world who study gait and cerebral palsy very seriously. This happens over and over and over again. Now, it's hard for us, and we don't say to the parents, because the parents don't want to hear this. The parents love their kids, and that's it. Parents love their kids, and they're trying to seek what's best for the kids. So this is just food for thought for you all. Be careful with magical treatments that are proposed as minimally invasive. Kids recover very quickly. Kids are going to be perfect the next day, and so on. Because normally these results are not shown anywhere, and we see them because they then come to us and say, okay, what's happening now? How can we go back to here? And sadly, sometimes we can't, there's nothing we can do, because once the muscle's cut, it doesn't regrow again, and it vanishes. And so we don't have those muscles to push us anymore. And this is another example, and this is an example from somewhere in the United States. And this very, very cool, intelligent woman allowed me to show this. She had hamstring surgeries 18 or 19 years ago. And she's around 32 now. And because she doesn't have, the hamstrings are very, very weak because they have been over lengthened. She now can't control her knees very well. You can see that they go backwards. And you can look at that, look at that. And because the hamstrings are very important muscles to extend the pelvis, she can't control the pelvis anymore, or very well. And now she's relying on canes and crutches and a walker. And there might be another way. This is not all natural history of CP. A lot of this is what we do to CP. Thank you so much. Now, before we go into the next session and to questions and answers, let's try, if I may ask you very humbly, let's try to discuss what we talked about today. If you liked what we did today, please give us feedback and we will continue. We'll go to the next step and the next step. Cerebral palsy is challenging, is tricky. In Australia, we say it's cheeky. I love it. It challenges my brain every time. So let's try and discuss what we did, what we showed you today. And then the next time, if you're happy with that idea, we'll move on to discussing further issues and further issues. Thank you so much for your attention.
Thank you guys both so much for a wonderful and informative presentation. I'm looking at the chat and we've got some great questions coming in. So I'm just kind of going to go through. I also just want to be mindful of our time. I know this is people's evenings. So again, if we don't make it to your question, please email us and we will get the answer back to you. I typed the email address in for you guys. If you didn't see it, it's cpcenter@cumc.columbia.edu. But until then, let's jump right in. So a lot of these questions have come in, and I'm going to throw them first to Dr. Kadis. There's a few in the chat about Botox specifically. There's some questions about Botox injections over a long period of time. Can that cause muscle atrophy? Do patients develop a tolerance with repeated Botox injections? What are your thoughts on some of these questions, and can you address that?
Sure. These are great questions and great things to think about. So patients, as far as we know, don't develop a tolerance to Botox. You can develop immunity to it where your body produces antibodies and makes the Botox ineffective. And we can certainly test for that. So we may see over time that it just doesn't work because you develop immunity to it. But it's not a tolerance where the more and more you get, the less and less you respond. We may see that it doesn't work as well because the dystonia or spasticity changes and we have to adjust our treatment. We can see atrophy though in the muscle with use of Botox over a long period of time.
Thank you so much. I think that kind of answers the next question of Botox about what is the long-term damage? Does it have long-term damage to the muscles? And I'm assuming that's kind of the same, a line in the same answer.
Sure, yeah, no, and so we can see atrophy. However, with that said, patients who do have dystonia and spasticity respond differently than if I were injecting a muscle that didn't have those movement disorders. So I have the most experience using it for dystonia, and we definitely see atrophy in the long run, but maybe not as much depending on the type of dystonia.
Dr. Selber, I'm going to go to you for the next kind of clump of questions. There's a few questions in relation to GM-FCS levels. One specific question was, can the GM-FCS level change? And following that, another person asked, can improvements in CP be made at any age, or is there a point in life where one is developed past a point of beneficial return? So I think those kind of go hand in hand in terms of, can you transition from a level 2 to a level 3? And can you maybe be a 2.5? Can you be in the middle of those levels?
Yes, those are really, really good questions, and thank you for that. I look, in children, there is a lot that we know. There's probably twice as much that we still don't know, But in gait analysis over the last 40 years has basically taught all we know nowadays about how to treat children with CP. I'm talking about the walkers primarily. The non-walkers, we need to keep their hips allocated. We can't let them dislocate because eventually they are going to hurt. So we do all we can to keep the hips in. We have to keep their spine straight, and there's a time for everything. And you know, they need to be able to sit properly, to lie down properly, and hopefully we can avoid pain doing this and that. With the walkers, if we mistreat them, we are changing the way what they're going to do in the long term, and I see it every day. So yes, GMFCS can change. Okay, what happens, I think, is because cerebral palsy, the lesion doesn't change. It happened to the brain and it's there. But the consequences of the lesion, which are the movement disorders, you know, spasticity is there every day. Dystonia is there every day. And those things are changing the skeleton because they're pulling too much or they're pulling in the wrong direction. So if a child starts as a GMFCS2 and can walk and with just a little bit of support and nothing is done, or whether all the muscles are cut and no muscles are left, eventually she will become a GMFCS3. Not because she was born a GMFCS3, but because she either has very severe deformities or in many cases, which is the case around the world still, you know, she had too many muscles cut too much. And what you can ask yourself, primarily the non-CP people that are watching, try yourself and mimic all the deformities that your child has and try and walk in that position yourself. And you see how hard it is. These children are champions. They are better than any athlete. So GMFCS can change, normally for the worse if treatment is incorrect or inappropriate or there's no treatment. We very rarely bring a 4 to a 3 or a 3 to a 2, very rarely. Sometimes what changes is what we call the functional mobility level. You know, a child was using walker, and then because the knees were really deformed and the feet and so on, and we fix those as much as we can and as well as we can, and they stop using the walker and they now use crutches, which is a bonus. So the GMFCS didn't change, but their mobility level and the level of assistance that they need changed a little bit for the better.
Thank you so much for answering that. There's a question that's in a similar vein, and I think this can go to both Dr. Salber and Dr. Katis since you see lifespan care. The question is, what do we know about the aging process of people with CP, and how is the wear and tear on the body different for those with CP? I think this is in a similar vein to the changing of the GMFCS levels. So either one, who wants to take a stab at that one?
Dr. Salber, you probably have more experience than me. Why don't you go?
So I'll use this question to answer half of the other question that I didn't answer regarding aging. Well, talk to me about aging because I'm there, and it happens to all of us, CP or non-CP. I have my own disability. I'm very short and everybody teases me because of that. So, which is okay. I'm short. You have CP, you have CP. Anyway, it's hard to age with CP. It's harder. Why? Again, because of those things that we explained. You know, the brain continues to send those messages to the muscles. The muscles continue to be stubborn, and they continue to be stubborn for a lifetime. There are treatments. There are treatments that resolve some of these spasticity and dystonia, but these treatments are not perfect. And because your muscles are stiff and they're going across joints, I suspect that the joints tend to suffer more quickly. In fact, this is an idea for research. If there's any researcher there, they can steal the idea from me, and I'm fine with that. But what I've seen is that a problem, in a non-CP patient leads sometimes to this much gait alteration. And the same problem in the CP patient leads to this much change. I'll repeat it. You imagine one problem. I can cite a few orthopedic issues. If you have no, and I see a few non-CP patients as well, they have this issue and their gait is, the way they walk is changed this much. And then I see another CP patient who has the same issue, exactly the same, a hip problem, a knee problem, whatever, and the way that the gait, the way they walk changes is this big. I don't know if I'm making sense. So I think the stiffness, the lack of perfect motor control, you know, how you move does impact. And there is actually quite a bit of data nowadays published in this regard. And we're trying to learn more about the adults. You know, everybody knows a lot about kids because we've been studying them in the gait lab forever. And now more and more people are going into this world of the adults, and we're learning more. And there's a lot of people now who found out, well, these kids grow, they still have CP, we need to care for them. I was lucky because people who trained me taught me that since early on. So I've been doing this for a little while.
Thank you so much. Kind of going along that same trajectory of aging, we had some questions in regards to pain. And Dr. Kaitis, I might throw this one to you as you touched upon some of the medications. So some of the questions were, you know, why do so many people with CP have chronic pain? And is that normal, not normal? And how do we deal with that? And is there a specific reason? Does it kind of par with the territory? What's going on there?
Sure. No, it's a great question. And I don't know that there's a simple answer for it, unfortunately, but pain is certainly very common. And I think I see it in almost most of my CP patients, and it can vary what causes the pain. You know, traditionally, as a movement disorder specialist, seeing dystonia and many different syndromes, dystonia itself is not usually painful, but it's the effect it has on the musculoskeletal system. So we can certainly see pain with dystonia. Spasticity and tightening can cause pain, and all of the effects that it has on the muscles and the bones, as Dr. Selber talked about, can cause pain. So we can certainly see it in that sense. And treating the movement disorders can help alleviate some of this, but we also sometimes have to use pain medications that specifically target the pain. So it can vary from patient to patient, certainly, but it is definitely a common problem that we have to try to tackle.
We had a question going off on that about the more holistic versions of pain management. Somebody asked specifically about CBD oil. Is that something that you might recommend or have heard anything about or seen any research about?
So, unfortunately, we don't have a lot of research for neurological conditions specifically, but we do know that it helps with anxiety, and that can certainly make when anxiety is up, everything else can feel worse, and is worse, actually. And so it can help in that sense. I have had patients who have responded well to it, and it has helped them with pain. So I certainly have seen it in my practice. I don't have great evidence for it in the literature, and so it's not something that I can specifically recommend, but I'm certainly open to it in my patients.
Great.
I don't know.
Yeah, no, that's perfect. Thank you. There's two specific questions. I think this is more for the surgeon in the room. One was, who's that? One is specifically, you touched on it very briefly, but SDR and long-term outcomes. And a second one was on tendon lengthening. And is that something that's, again, that in quotes, word normal, right? What is normal at this point? But is tendon lengthening as a child something that we see in adults with CP that have had this in their past?
I'm not sure if I understood your second question.
Let's break them up. Let's go to the first one first. So the first question, I'll separate them. Do you have any suggestions or research about the long-term outcomes for people who have had SDR?
Okay, yes, that's a good question. So rhizotomy is a surgery where the neurosurgeon, as you probably all know, the neurosurgeon goes into the spinal cord down below, finds the little nerves that are going to the legs. The neurosurgeon divides those nerves in what they call rootlets. See a nerve like, the old telephone cable. For those of you who are my age, I don't know what is your age, because now it's all digital. But when I was 10, a telephone cable, you cut it across, and trust me, I did that to my grandmother's telephone one day. And you see all these little cables inside. And the nerve is like that, okay? So what they do is they open up the spine. They find the nerves that very specific nerves that are going to very specific muscles. They know which muscles are spastic, primarily, and better if the child has had gait analysis. Back in Melbourne and in many centers around the world who I consider good centers for cerebral palsy treatment, nobody gets a rhizotomy without gait analysis, because you need to understand what's wrong with gait before you go there and cut the nerves. How can you just simply cut the nerves? Just examining the muscles. We know that sometimes we see a muscle, we examine the kid lying down, and one muscle may look very spastic, and then when we put them through the gait lab to study their gait, that muscle is not spastic anymore. So rhizotomy is good when a patient has spasticity, okay? It should not be done in general in dystonia. It's normally done to the GMFS 1s, 2s, and 3s to alleviate spasticity so that the muscles work better. Without spasticity, the kid can walk better. Sometimes it's done in 4s and 5s, but for other purposes. If you find the right patient with the right indication, and it's done by someone who understands what this person is doing, understands gait, works collaboratively with everybody in the team, the outcome is going to be relatively okay, even though long-term results are still up and down. If you don't find those real conditions, I would be hesitant.
Thank you so much. We've gotten a few questions about SDR, so I think that's very helpful. The second question.
We'll talk about SDR in the future. So hold your, do you say in America, hold your horses?
Hold your horses, it's coming, guys. That's a little.
We're gonna get a neurosurgeon. Remember, I'm an orthopedic surgeon. I'm a mechanic. I only know about muscles and bones. We're gonna get the smart guy, and Lynn she is smart, but she's not a surgeon. So we're gonna get a neurosurgeon that we think and we're gonna have this neurosurgeon talking to you.
Great. But since we don't have that, let's go to the orthopedic surgeon. So for the part 2 question, I'm just going to clarify. Somebody asked specifically, and this might be too specific to answer in the panel. If that's okay, we'll take it offline. But somebody had asked about having a specific tendon lengthening of a leg to match the other leg. And is something like that normative for people with CP?
Yeah. Look, the problem with lengthening tendons, the problem of tendons is that they are too superficial. Most of them run just under the skin. So you can cut them very easily. You don't even have to open the skin. You put a little blade through the skin and cut it. You have no control what you're cutting, but you can cut it very easily, okay? The problem is that every time you're cutting a tendon, Remember, the tendon is the continuation of the muscle. You have the muscle belly here, the red part that I showed you, then the muscle is attached to the tendon, and the tendon is attached to the bone. The tendon is a piece of sling or a rope that connects the bone to the muscle. So when the muscle pulls, the tendon goes with it, and the tendon is attached to the bone, and the bone moves. So when you cut the tendon, you're disconnecting the muscle from the bone, okay? Now, sometimes in CP, that's very, very useful. And there are very specific situations where I do that, okay? But very often what happens is that people think, because they don't understand pathological gait, they don't have gait analysis, they couldn't care less about gait analysis, they think that that muscle's, and sorry that I'm too straightforward, but that's what I think. And they think that this muscle is tight because it looks tight and feels tight, and they go there and cut it. But very often what we see through gait analysis is that the muscle is not tight. In fact, it's the opposite. The muscle is there trying to hold things up. And then you cut that muscle off, and then the patient can't do the activity anymore. And nobody knows why. Well, because you don't have a muscle anymore. So anytime and every time in a walker, I consider a tendon release or a muscle lengthening, I sweat a lot to make that decision. And I think, you talk to my wife, there aren't many nights that I don't wake up at 3 a.m. thinking about, am I going to do that or am I not going to do that? And it's real. And of course, gait analysis helps us a lot with those decisions. And I promise you, we are going to have one of these sessions as well, only in gait analysis, so that you guys understand what this technology is. It's not new. It's been around for more than 40 years. And, but in many parts of the planet, people still have a hard time with it and a hard time reaching it, unfortunately and sadly.
Well, thank you so much. I'm looking at the time. I don't want to keep everyone over. Thank you to our wonderful panelists, Dr. Selber and Dr. Kaitis. I think everyone learned a lot tonight. Thank you to our great participants for joining us this evening and asking wonderful questions. Again, I'll just repeat, if we didn't get a chance to get to your question, I apologize. We just ran out of time. And please send it to us via email and we will make sure to get back to your questions. Again, the email is cpcenter@cumc.columbia.edu. Thank you, everyone. Reach out if you have any further questions, and we look forward to seeing you at our next webinar on TBD when that's going to be. Have a great night, all.
Thank you all very much.
Bye.
Thank you really much. Bye-bye.
Yes.